Good morning, everyone. The topic of my presentation is facilics, and my moderator is Dr. Shelly ma'am. The term facilics is derived from the Latin root facilis, indicating grace in the movement. It is the study of how interviewers structure interviews while gathering data. Example, what topics they choose to explore, including why and when, how they go about exploring those topics, and how they make transitions from topic to topic, including the manner in which they approach this task while managing tight time constraints. The practical application of facilics is composed of two activities. First is learning how to mindfully be aware of how we are structuring the interview as it proceeds, a process that will form the foundation for our ability to intentionally and sensitively shape the data gathering process. And the second is learning how to apply specific facilic interviewing strategies and techniques that can facilitate the graceful procurement of the unique database. Now we'll study about the introduction to the practical application of facilics. The part one is learning how to tag the flow of interview, like what topic and when to start. What information is important to gather in a full intake assessment? In this regard, the concept of region is the first facilic concept that we need to examine. A region is defined as any section of an interview lasting at least several sentences in which there exists either a unified attempt to gather data related to a specific topic or a unified focus upon the process of interaction or upon a non-data gathering task. In this sense, two general categories of regions exist. First is the content regions and second is the process regions. So a content region is any area of an interview in which the primary focus of the interviewer is the delineation of a specific database. Like when we ask about the history of presenting problem or stresses, then interviews perspective, history of presenting illness, comorbid diagnosis, social history, framework for meaning and spirituality, the family history, uncovering of suicidal or homicidal ideation, planning, behavior, and intent, the past psychiatric history and treatment, developmental and psychogenetic history, medical history, and the cognitive mental status. Facilics provides us with the interviewing approaches and strategies to do so successfully. When a well-trained clinician applies Facilic principles, it is rather amazing how much useful information can be sensitively gathered in a mere 50 minutes. It is the patient who benefits greatly from the clinician's application of this hard-won skill set. Now the second is the process regions. In a typical process region, the interviewer is less interested in focusing on the content and the gathering of a specific database than on the process of the interview itself. What is happening between the clinician and the patient or in the patient's head as the interview is proceeding. There are also atypical process regions where once again the focus is not on data gathering per se, but on a specific interviewer task such as providing psychoeducation or a specific therapeutic activity such as crisis intervention. There are various process regions. The first one is free facilitation regions. It is one of the foundations of all interviewing. It is a traditional method of non-directive learning. It is creating an atmosphere in which it is optimally conductive for the interviewee to feel safe enough to begin sharing the problems. The interviewer is able to wander freely to whatever topics chosen while the interviewer maintains a non-directive attitude. The major interventions of the interviewer are usually facilitating head nods, empathic statements, both low and high in balance, and simple facilitating statements. Uncovering of information that the patient reveals spontaneously without direction from the interviewer. And it is also used to improve the engagement. So this is the first conversation in which we'll see the free facilitation regions.
अरे हम दुनिया को बिल्कुल अलग नजरिए से देखते हैं वो हमेशा पैसे की चिंता करती है और मैं दुनिया की मैं नहीं जानता बस एक खेलने की जगह की तरह देखता हूँ बिल्कुल बुरा हम हमेशा लड़ते रहते हैं हर छोटी छोटी बात पर। और बताऊं, कुछ शारीरिक या ऐसा तो कुछ नहीं है, लेकिन सच में चोट पहुंचाने वाली बातें होती है। वो हमेशा मुझे चोट पहुंचाती है। मैंने उसे वो शब्द भी कह दिए जो मुझे नहीं कहने चाहिए थे, और मैं उन्हें सच भी नहीं मानता, और वो भी नहीं मानती। और फिर हम दोनों जिंदगी के असल मायने को मिस कर देते हैं, जो असल में महत्वपूर्ण है। जैसे हमारे पास पर्याप्त भोजन है, हम दोनों साथ हैं, और हम दोनों स्वस्थ हैं, और भी बहुत सारी महत्वपूर्ण चीजें। और बताइए। जैसे हमारे बच्चे, हमारे दो खूबसूरत बच्चे हैं, वो मेरे लिए दुनिया है। उनके बारे में बताओ। वो सबसे अच्छे हैं, बहुत स्पेशल हैं। And then the navigation keeps on talking about this.
So this was a brief example, and it may help to clarify when a section of an interview can be labeled as a free facilitation region. Most of the interviewers' responses are merely the facilitating statements in this, open-ended questions or gentle commands. The second is the transformational regions. The interviewer actively attempts to decrease a specific roadblock to communication stemming from unconscious defense mechanisms or conscious feelings of anger or defensiveness in the patient. They are the areas rich in information for understanding what makes the patient tick if approached as an area of collaborative discovery by the interviewer instead of an example of patient opposition. The defining characteristic remains that in a transformational region, the interviewer consciously is attempting to resolve a communication roadblock as opposed to gathering information as would be seen in a content region. This is the second. जानते हैं, मैं सच में सोचती कि मुझे आगे आपके पास चिंता मुझे बस थोड़ा सा अच्छा लगेगा अगर मैं किसी थोड़े से बड़े उम्र के व्यक्ति से बात कर रही हूँ। एक बड़े उम्र के क्लिनिशियन की तरह से सारी मदद कर सकती हूँ, जो एक छोटे उम्र का क्लिनिशियन नहीं कर सकता। वो समझ सकता है कि मैंने क्या कुछ देखा है, इसमें कोई शक नहीं है। उसके पास मेरी जैसा अनुभव है, उसने ज्यादा जीवन को देखा। तुम जानती हो, मैं इससे एक पल के लिए भी विवाद नहीं करूंगी। ये सच है कि मैं तुमसे छोटी हूँ, और इसके परिणाम स्वरूप मैंने वही चीजें नहीं अनुभव करी है। ये एक सच्चाई है, और तुमने एक इम्पोर्टेंट पॉइंट उठाया है। मैं यही उम्मीद कर रही हूँ कि मैं तुम्हें और मुझे दोनों को साफ साफ समझने में मदद कर सकूं कि आप किस अनुभव का सामना कर रही हैं और क्या समाधान संभव। मेरा एक फायदा है कि मैं तुम्हारी उम्र के कई लोगों के साथ काम किया है, और उन्होंने मुझे कुछ क्लेवर तरीके बताए हैं जिनसे वो कुछ समस्याओं का समाधान निकालने में सफल हुए। जो तुम बता रहे थे, मूल रूप से उन्होंने अपने अनुभवों को मेरे साथ बांटा है, जैसे कि तुम कर रही हो, और उन्होंने मुझे कुछ सिखाया है, जैसे कि तुम कर रहे हो। शायद कुछ उनके अनुभव मेरे नहीं, तुम्हें उपयोगी हो सकते हैं। क्या ये कुछ सेंस में आता है? मैं तो यही उम्मीद कर रही हूँ कि तुम मुझे मौका दोगी उनके कुछ विचार बांटने का, और देखो कैसे वो तुम्हारे अपने विचारों के साथ मैच करते हैं। क्योंकि तुम सही कहती हो, एक्सपीरियंस मैटर करता है। मैं उम्मीद करती हूँ कि हम एक अच्छी टीम हो सकते हैं। इस तरह से कम मैं यही उम्मीद करती हूँ। अगर आज हमारे सेशन के अंत में तुम्हें अभी भी अनकंफर्टेबल लगता है, तो हम बड़े उम्र की के बारे में बात कर सकते हैं। ये कोई बड़ी बात नहीं है। मैं बस उम्मीद करती हूँ कि तुम मुझे पहले मौका दे सकती हो, क्योंकि मुझे ये फीलिंग है कि हम मिलकर इस चीज को तुम्हारे लिए सुधार सकते हैं। क्या ये आपके लिए ठीक है? सिर्फ देखो कैसी बाकी सेशंस होते हैं। हाँ, शायद तुम मुझे बताकर मदद कर सकती हो कि लोग तुम पर अपनी उम्र के बारे में कैसे दबाव डालते हैं। करने की शुरू हुआ, इसने मुझे लगभग 3 साल पहले छोड़ दिया, और आप देख सकते हैं छोटे उम्र के in the following dialogue, we see an interviewer deftly navigating a potential point of disengagement arising around the clinician's age, for he is 40 years, very much younger than the patient. Clearly, the interviewer is focusing upon addressing the patient's hesitancies, not upon gathering a specific database. Third is the psychodynamic regions. The interviewer asks questions but is more interested in how and why the patient responds as opposed to the content of what the patient says. In general, the clinician attempts to answer the questions such as how reflective is the patient? Does the patient have much insight? How does the patient respond to interpretive questions? How good is the patient's observing ego? It may help determine the suitability of the patient for specific types of time-limited psychotherapy. It provides an insight into the patient's intellectual development, ego strength, defense mechanisms, self-concept, or genuine readiness to engage in treatment such as substance abuse counseling. To answer the questions in the psychodynamic region, the patient must reflect and offer an opinion. So this is the third conversation. कब्जा रखेगी ये मेरा हर कदम होता होना चाहिए आपको क्या लगता है कि आपके पिताजी के व्यवहार का आप पर क्या प्रभाव हुआ उन्होंने मुझे डराया है मैं उनसे डरती हूँ तो कौन जाने शायद मैं इसी वजह से उनकी दूरी बनाए रखती हूँ थोड़ा अजीब है क्योंकि जब मैं बच्ची थी तो हमेशा उनके आसपास रहना चाहती मैं उनके वापस आने का इंतजार करती थी जब वो काम पर जाती और ये थोड़ा सही है लेकिन मैं सोचती थी कि शायद उनके पास कुछ परफेक्ट खिलौना हो मेरे लिए और एक छोटी सी गुड़िया याद है मुझे बड़े बड़े बड़ी बड़ी काली आंखें थी बस एक छोटी सी गुड़िया थी लेकिन मेरे लिए इम्पोर्टेंट और कुछ और कहने लायक नहीं है बस यही है कि हमारे बीच में जो चीजें हो गई वो थोड़ा सा दुख दे आगे के बारे में बात करते हैं तो आप कैसे महसूस करते हैं Here, the content is clearly taken a second place to the process. The interviewee's responses suggest a willingness and a certain degree of proficiency at self-exploration. This type of region can occur anywhere in an interview, often appearing frequently between the content regions. Now, the second is the practical tips for applying facilic principles to the exploration of regions. Before beginning the interview, make a tentative determination of which content regions are most appropriate, considering time constraints, the needs of the patient, and the goals of the interview. At the 5-minute point, note how well the scouting region is proceeding. Make appropriate adjustments and a decision as to how you are going to move into the body of the interview, thus avoiding an overly long scouting phase. Begin gently but persistently, structuring as soon as you leave the scouting region and during the second 15 minutes. Generally speaking, once within an appropriate content region, it is often useful to expand it thoroughly. If the patient pivots into a new area, it is usually best to gently pull the patient back to the current region until it is completed. The exception of this principle occurs if the patient pivots into a highly charged or sensitive area such as suicidal ideation or incest. Avoid the overuse of free facilitation regions during the body of the interview. During the remaining interview, occasionally, at least every 5 to 10 minutes, monitor the progress of your data gathering and adjust your pace as needed, paying particular attention to where you are with regard to your structuring every 15 minutes of the interview. In the second quarter, be sure to avoid creating a dead zone regarding information gathering. If at 30 minutes you are behind, consciously decide what topics and data to not explore and proceed to naturalistically explore at a normal pace whatever regions you have decided are necessary. And leave adequate time in the last quarter for a graceful closing and termination phase. Now, how to explore a content region in a sensitive fashion. The process of exploring a given content region is referred to as the expansion of the region. Two methods forming somewhat opposing extremes can be defined as stilted expansions and blended expansions. In stilted expansions, the expansion lacks a feeling of conversational flow. The interviewee is asked a series of questions that appear somewhat forced because the interviewer is rigidly attempting to ask specific questions regarding the needed data points of the content region. This type of expansion may cause interviewees to experience the unpleasant feelings that they are being interviewed as opposed to talking with someone. The fourth. मैं ये नहीं जानती कि कहाँ ले जाएगा, बस मुझे ये पता है कि मैं बहुत ज्यादा मुझे मुश्किल होती है। मेरे दिल एक कभी भी नींद आने की कोशिश करती हूँ तो मुझे संतुलन महसूस नहीं होता, पढ़ने में भी ध्यान नहीं लगता और आपका एनर्जी वो कैसा रहता है, काफी इम्बैलेंस। समझाना मुश्किल है लेकिन कभी कभी मुझे कुछ करने का मन नहीं। The particular interview seems doggedly intent on expanding the depression region, specifically the neurovegetative symptoms of depression. This style of expansion exhibits a mechanical quality as if the interviewer has a list of questions to reel off. Such rigidity characterizes the stilted expansion. Now, the second one is the blended expansion. The interviewer once again focuses on a specific content region. However, in this expansion, the interviewer attempts to blend the questions into the natural flow of the dialogue. Rather than feeling like they are being interviewed, this type of expansion creates our interviewees a sense of gentle flow which tends to foster a conversational feel. Moreover, this type of interviewing, by decreasing the anxiety of the patient, may enhance both the quantity and validity of the database as well. This is the fifth one. सच में क्राइसिस पॉइंट तक पहुंच गई। मैं ये नहीं जानती कि ये सब कहाँ ले जाएगा, बस मुझे ये पता है कि मैं बहुत ज्यादा
सर आपने काफी कुछ सवाल चीजों ने आपको कैसे इफेक्ट किया?
उदास रहती हूँ, हमेशा लगता है कि मेरी एनर्जी खत्म होती है, मैं हमेशा थकावट महसूस करती हूँ। जीवन एक बड़ा काम है।
कुछ ऐसे रोजाना काम बताइए जो आपको अपमानित लगता है।
हर कुछ, हर चीज फेसबुक पेज भी चेक करना। मैं फेसबुक का बहुत बड़ी शौकीन हूँ, मेरे पास हजारों फ्रेंड्स हैं। पहले मैं दिन भर काफी बार मैसेज चेक करती थी और मैं हमेशा कुछ कुछ पोस्ट करती रहती, लेकिन मुझे अब कुछ भी फर्क नहीं पड़ता है। ये एक और काम रखता है, बहुत अजीब है। मेरी जिंदगी में जो भी नॉर्मल था वो अब सब खराब हो गया।
मुश्किल लग रहा है आपकी नींद पे भी कोई असर हुआ?
बिल्कुल, शायद यही वजह है कि मैं महसूस करती हूँ, बस आराम नहीं कर सकती, मेरी नींद खराब हो गई।
इसके बाद कौन
नींद नहीं आती है, नींद आने में कई घंटे लग जाते, दिन भर थकान महसूस और मैं इतनी चिड़चिड़ी हो गई हूँ कि मैं ध्यान भी नहीं लगा सकती, पढ़ने का भी मन नहीं करता जो मुझे नींद आने में मदद करे।
ये काफी बुरा लग रहा है। जब आप सो जाते हैं तो क्या आप रात भर बिना फिर सो पाते हैं?
कभी नहीं, मैं रात में 4 या 5 बार तो उठ ही जाती हूँ और लगभग 5 बजे रोज मैं जाग जाती हूँ जैसे किसी ने मुझे पकड़ा। In the following illustration, a blended expansion unfolds with a clinician once again exploring the diagnostic region of the depression. In the above, in this dialogue, in the but in the above dialogue, the same region was expanded in our first illustration. Now, the first one which we showed here, it was the blended expansion. But this time, the questioning appeared to flow naturally, generating an increasing flow of information. The interviewer's questions seemed to relate directly to what the interviewee was saying, thus creating a sense that the interviewer was with the interviewee. A nice example of a good track. Now, part third is the facilic gating, that is, the fine art of making graceful transitions. As a conversation or an interview passes from one topic to another, different types of transitions occur. We refer to the actual statement or questions joining two regions as gates. Five major gates are the most common, which we'll be studying here. First is the spontaneous gate, the natural gate, then the referred gate, the implied gate, and the phantom gate. Spontaneous gates. It unfolds without any effort of the interviewer. Instead, the transition results from a change in topic unilaterally initiated by the interviewee. These gates occur when the patient spontaneously moves into a new region called as more about that, or how do you mean? Spontaneous gates create movement that seems unblemished by effort or apparent structuring. The concept of spontaneous gates and pivot points provide us with a new way of conceptualization, both the wandering interview and the unguided interview. This is the sixth.
किस चीज के बारे में बात कर रहे हो? आपने पार्टी नोटिस किया नवंबर का महीना है गार्डन से भर्ती हुई है। आमतौर पर वो साफ तरीके से इकट्ठा करके रखी जाती है जैसे एक छोटी सी खेती लेकिन अब नहीं। क्या आपको लगता है कि आप जिम जाना है अभी बुराई के पास? बिल्कुल नहीं, सब कुछ इतना बुरा लगता है। मैं जिम में भी कई महीनों से नहीं गई। सब कुछ पहले से काफी अलग है। पहले वो भी समय था जब मैं एक जगह बैठ नहीं पाती थी, बहुत एक्टिव थी, जैसे कि बहुत पावरफुल। मतलब बहुत एक्टिव, मैं बहुत एक्टिव थी, जिम जाती थी, क्रिकेट खेलती थी, फुटबॉल खेलती थी और सब कुछ। बहुत मुश्किल था ऐसे कि किसी को ढूंढना जो मुझे ऐसे किसी को ढूंढना जो मुझसे मुकाबला करे। आपने कभी बहुत तेजी से काम किया? कैसे मतलब? कभी कभी किसी को इतनी एनर्जी मिल जाती है कि वो काम करना मुश्किल हो जाता है। असल में एक समय था जब स्लो डाउन होने की कोशिश की। मेरे बारे में थोड़ा लगभग एक साल पहले और मैं बहुत कम सोई ऑलमोस्ट एक हफ्ते के लिए। मैं रातों भर काम करती थी, गाड़ी धोती थी और तेजी खींचती थी। नींद की जरूरत नहीं पड़ती थी। आपने ध्यान दिया कि आपके तेजी से बढ़ गए थे। मैं उड़ान भर रही थी, सब कुछ क्रिस्टल क्लियर लग रहा था और बिजली की तरह तेजी से बढ़ रही। ये अजीब था।
In the following example, a spontaneous gait provides an essential unnoticeable movement from the expansion of the depressive symptoms into a new region. In this example, two topics are being discussed sequentially. In the first content region, the interviewee's symptoms of depression are being explored. In the course of this exploration, the interviewee unilaterally brings up a statement that suggests a different diagnostic region, the one dealing with the. The second one are the natural gates. A natural gate consists of two parts, the cue statement and the transitional question. A cue statement consists of the very last sentence or two made by the interviewee, and it contains content material that can be creatively used as a bridge into a new region by the interviewer. The transitional question is the actual question asked by the interviewer that makes a bridge from the cue statement into the new region. That is, in contrast to the spontaneous gate, the clinician, not the patient, is moving the conversation into a new region. 7.
क्या अपनी दुकान का काम का आनंद लेने में सक्षम है? तुमसे मैं गाँव से आने लगा हूँ, तुमसे तो कुछ भी नहीं कर पा रहा हूँ, मेरा तो मेरा मन ही रहता है। और ये काफी बुरा इंसान भी है। और इसके बारे में क्या बताइए, कैसा लगता है आपको? काफी दुख रहता है, जिंदगी वैसी लगती है जैसे थी। मैं हमेशा थकावट महसूस करता हूँ, मुझे बीमारी क्या मतलब पिछले कई दिनों से नींद लगभग कमाने लगी है मुझे। नींद भी काम की तरह लगता है। नींद आने में मुझे हमेशा मुश्किल होती है और फिर रात में जाता है। नींद अगर आती है तो 4-5 बार उठ भी जाता हूँ और नींद आने से 2 घंटे लगते हैं। क्या आपने कभी किसी तरह के शराब या अल्कोहल का इस्तेमाल किया है जिससे आपको नींद आने में नहीं मदद करे? कभी कभी शराब पीना मुझे नेचुरल रहता है रात में। आपको नींद आने के लिए कितना पीना पड़ता है? कुछ बियर या फिर दोस्त रहता है। आमतौर पर एक दिन में कितनी शराब पी लेते हैं आप? और मैं अंदाजा लगा रहा हूँ तो 6 4 या 4, मतलब मेरा शराब का ऐसा कंट्रोल है कि आप किस तरह के ड्रग्स पसंद करते हैं? जिससे आपको कभी कभी दो ही पी लेते हैं।
In the following conversation, we'll see a transition made from the content region covering depressive symptoms, which the interviewer has been exploring for the last few minutes and currently feels that she has enough information to make the diagnosis, into the drug and alcohol region. This smooth transformation will be made via natural gate. Now, this is the how the natural gates are utilized as smooth transitions. Like there is a stressor. My argument with my husband are so bad that I just don't know what's happening anymore. So the first transition questions can be, with all these tensions mounting, have you had any thoughts of wanting to kill yourself? This goes towards the lethality region. Second is, how have all these stresses affected your mood? This goes to the depression region. Third is, with all these stresses, have you been drinking at all in an effort to calm yourself? This goes towards the alcohol and drug region. And fourth one is, some people hold all their anger in and other rarely let it out. Maybe even throwing things like glasses or plates. How do you handle your anger? So this goes toward the borderline personality region. These are how the natural gates are utilized for the transitions. Third one are the referred gates. A referred gate occurs when the interviewer enters a new region by referring back to an earlier statement made by the interviewee, often many minutes earlier. Typical referred gates begin with the phrases such as earlier you have said or I want to hear more about something you mentioned before. To the interviewee, a referred gate meta communicates. I have been listening very carefully to you. Moreover, I want to learn more about something you said to see if I can help. It is a wonderful example of a structuring tool that is simultaneously a powerful engagement technique. Also, it allows the interviewer to enter a fresh region smoothly at almost any place in an interview. It remains extremely useful for re-entering a region that was not fully expanded earlier. Structurally, a referred gate lacks an immediate cue statement because the cue has been taken from a previous area of the interview. In the following conversation, we will enter the interview at the end of a psychodynamic process region in which the patient's feeling concerning his siblings have been explored. At this process region winds down, the interviewer, by referring to something that was said much earlier, will enter a content region traditionally viewed to be difficult to gracefully broach psychotic phenomena through the use of a referred gate. Fourth one are the phantom gates. It lacks a cue statement and also lacks previous referential points as seen in referred or natural gates. In short, it jolts the spontaneous flow. With regard to the possible utility of phantom gates, two instances come to the mind. First, when dealing with a wandering interview, phantom gates may be useful in focusing the patient, especially if milder forms of focusing have been unsuccessful. And the second is use of phantom gates arises during the exploration of certain psychodynamic regions. Specifically, if one wants to catch a patient off guard in order to observe the patient's spontaneously occurring defenses, then an unexpected phantom gate may be very effective. Phantom gates may also help one break through the communication roadblock caused by a patient bent or manipulating the interviewer, or as a method of disrupting a rehearsed interview when used to introduce an effective interjection. In a less antagonistic sense, phantom gates may also be utilized when attempting to help patients reflect upon themselves through the use of interpretive questions. Interpretive questions may assume more bite if asked at an unexpected moment. The last one are the implied gates. Implied gates are structurally similar to the phantom gates. They do not cue off the patient's immediately preceding statements, as in the natural gate. They do not refer back to earlier statements, as in the referred gates. And the clinician, not the patient, as seen in the spontaneous gates, initiates the movement into the new topic. There is one important difference between the implied and the phantom gate. The implied gate enters a region that is topically similar to the immediately previous regions. Implied gates can frequently be used to enter new regions smoothly. In fact, occasionally the clinician may simultaneously expand two regions whose contents are similar in nature. For instance, one can easily expand the generalized anxiety disorder region and the major depressive disorder region in a parallel fashion because anxiety often plays a role in both disorders. So, summarizing the principles of facilics, when the patient spontaneously moves into a new region, the clinician always has the choice of whether to follow it or not. These decision movements are called the pivot points. Natural gates in which the clinician enters a new region by cueing directly off the patient's preceding statements or two offer another method for creating smooth transitions and should be employed frequently. These natural gates often play a particularly effective means of intentionally structuring an interview while conveying an unstructured conversational feel to the interviewee. Referred gates, in which the clinician refers back to the earlier statements by the patient, offer effective methods of re entering poorly expanded regions or bringing up new regions, and once again provide a graceful tool for sensitive structuring. Referred gates are also useful for trying in insensitive or awkward regions, such as the cognitive mental status examination, for the patient feel that this new topic appears to relate naturally to the previously referred to dialogue. Implied gates allow one to join topically similar regions and can also provide parallel expansions of related regions. And phantom gates should be generally avoided unless used for a specific purpose, such as a tool for derailing a rehearsed interview when using effective interjection. This is my reference. Thank you. There is one important difference that is there between the implied and the phantom gate. That the implied gate it enters a region that is topically similar to the previous region, while in the phantom gate it is not so. In implied region, uh, the region that when we enter a region, it is similar to the previous region which we were going through, while in phantom region it is not. This is mostly the main difference which is there. Yes, ma'am. How is it that how is it different from other? I mean, what difference is that? No, ma'am, there are five type of gates. Three gates I've explained through the conversations which I have seen here. But ma'am, first one is the spontaneous gate, in which we spontaneously transition from one topic to the another, ma'am. Like, ma'am, like, ma'am, yes, ma'am. Ma'am, in spontaneous gate, when we go through the spontaneous gate, ma'am, from one topic to another topic, we spontaneously come from one topic to the another topic, ma'am. Like, here in a spontaneous one, ma'am, the first when the patient was being interviewed, it was for depression. But ma'am, it transit spontaneously. The conversation came towards the main phase which we had previously. So, ma'am, this was the spontaneous transition. Then, ma'am, the in the ma'am natural gate, first they were discussing about the depressive phase, but ma'am then ma'am natural gate it transitioned from the depressive phase to the alcohol phase. Like when they started to ask like why do you take alcohol, मतलब you have to take alcohol if you want to sleep. अगर आपको नींद आने के लिए alcohol लेने की जरूरत पड़ती है किसी और चीज की. So ma'am, through natural gates we can transition into any area by this. Now for the transition, ma'am, from one, how we transition from one topic, if we're talking about one topic, then now we can go to another topic for various. And referred gate was there. Ma'am, in referred gate, the first of all, the patient was discussing about how he feels about his brother when he comes home. Then gradually, ma'am, from there, he shifted. Like previously, they were talking about the topic, like कि आपको आवाजें आना और ये सब चीजें. Ma'am, after that, they started talking about the brother, that how he feels when his brother comes home. But ma'am, in between, the clinician shifted into the another topic. He came back to the previous topic from the first. Like पहले आपने बताया था कि कभी कभी आपको अकेले होते हैं तो आपको कैसा लगता है. So ma'am, this is the referred case. When we take a point from the previous point from the conversation and then we start asking about that. And ma'am, the phantom gate and implied gate are not much used, ma'am. That's why I hadn't put any conversation for that. The thing is- First time. So now I'll have this in the coming interviews. Yes, ma'am. Addition of light is presented practically applied, and that's why the most effective in the previous this discussion. Last time I think there were 45 from the business to 70. So that the demo is good for the ones who are presenting and for the ones who are listening to understand better. So that how this should be regarding open and closed ended. Yes, it's something that is happening.